And now we're going to move into the next section of medications that can be used to help manage insomnia. So we have two products here, melatonin and Rameltion or Rosarim. Melatonin is an over-the-counter product. It is not FDA approved, but it can be used to help kind of re-regulate the circadian rhythm. So we have these melatonin receptors. Melatonin is technically a hormone that your brain makes in response to changes in light. So it's a bit unique in that it doesn't have that like negative feedback that we see because the stimulus is an external stimulus versus, if you have too much thyroid hormone in your body, then your product that stimulates thyroid hormone production gets suppressed. We don't really have that. It's literally day-night cycle. It is associated with a decrease in sleep onset latency and an increase in total sleep time. However, it's important to realize that supplements should be used cautiously and the dose should be considered cautiously. A lot of people take too much melatonin, likely. Now, the bioavailability is quite low. So our body only makes like less than a milligram of melatonin typically. But if you're taking 10, 20 milligrams, you're still not getting as much as 10 or 20 milligrams because it has poor bioavailability, but it's still probably significantly higher than what the body will typically produce on its own. And we're not really certain what, if any, true long-term adverse effects of that can happen. It might have some hormone disruption. However, 1 to 2 milligrams of a quality product, ask your pharmacist which ones are quality, can be helpful for some people. People often take it too late in the evening. They should be taking it really a couple hours before they go to bed. And if it's for insomnia, taking it pretty consistently for several weeks is going to be better than taking it intermittently. Now, Rameltion is a prescription product that's FDA approved. It is an agonist. It's a bit more specific to some of the melatonin receptors, but has been shown to decrease sleep onset latency and is pretty well tolerated. So, your standard headache, stomach upset, dizziness, nothing super interesting or unique when it comes to side effects associated with Rameltion. However, it is recommended not to take it with a high-fat meal. I'm not going to test specifically on that for anyone who's getting tested on this. And I did want to just mention there is another product kind of similar called Tasimeltion, which is specifically for something called non-24-hour sleep-wake disorder and Smith-Magenis syndrome. Non-24-hour sleep-wake is usually caused by someone who is fully blind, so their brain cannot perceive changes in light because they can't see changes in light. So this helps to kind of replicate that experience for them. And our last big group of drugs here is our dual orexin receptor antagonist, right? So our DORAs, as we sometimes refer to them, and that's daridorexant, lemborexant, and suvorexant. These are all FDA approved for insomnia, and these work a little bit differently. So these work by turning off wake, right? So our Z drugs are benzodiazepines. They increase the sleep side. These block the wake side, okay? Now, these medications work by binding to orexin A and orexin B on those receptors, OX1R and OX2R, to suppress that drive for wakefulness. And they've been shown to increase total sleep time, decrease sleep onset latency, and decrease wake after sleep onset. They tend to cause sleepiness as a side effect, headache, dry mouth, abnormal dreams, which we see with some of these medications that affect sleep. The unique stuff to be aware of, though, are things like sleep paralysis and complex sleep behaviors, as well as hallucinations. If someone has narcolepsy, this narcolepsy is largely associated with the orexin system being dysregulated, so we're further kind of dysregulating it in a way, and should not be used because it'll worsen things like that sleep paralysis, for example. It should be taken very similarly to what we talk about with the zolpidem, where you shouldn't really eat for a couple hours and have a full night's sleep ready and available for you. Now, moving into the things that I don't recommend, right? So antihistamines, no. Hydroxyzine is used. It is a little bit less like drying. So things like diphenhydramine or Benadryl, doxylamine, these products tend to be very drying, and that they have what's called anticholinergic effects, which is that drying effect. And those drying effects long term have been associated with cognitive decline and dementia. And the effects of sleepiness tend to wear off over time. Okay, hydroxyzine can be used. It's a prescription product. It is approved for that. Again, we try not to use them long term for the same things that we'd mentioned before. However, the benefits aren't as clinically significant. So things like sleep latency and total sleep time, but can cause sleepiness, obviously. Those drying effects, and then tolerance, which can sometimes be quite quick after several days. Antipsychotics, as I mentioned before, not great data. Some people do swear by using things like Seroquel or quetiapine to help them sleep. However, the risks versus benefits there really need to be considered because over time we see risks on people's metabolic labs and values. So things like diabetes, high cholesterol, high blood pressure. There's a warning for potential risk of increasing mortality in dementia-related psychosis. This is a risk versus benefit for sure there. And potential for things like movement disorders, and in some cases very difficult to treat, or potentially even permanent movement disorders that we don't see as much because we monitor and we use more conservative dosing a lot of times. But generally the risk is going to outweigh the benefit. However, if someone has bipolar disorder, schizophrenia, or another indication for an antipsychotic and difficulty sleeping, then this could be very well appropriate to try. So from a kind of wrap up treatment algorithm here, if someone comes in with insomnia, we want to assess those habits and the stressors, right? If there's something underlying, is there something manageable that we can try to address before really looking through to potentially using a medication, okay? If there is a short-term stressor that we know is going to resolve itself, a very small course of like an Ambien, an NBRA, or a Z drug, totally reasonable. If it's not, CBTI, right? So cognitive behavioral therapy for insomnia should be recommended. If it doesn't work, or they're not able to use it or appropriate to use it, then thinking about using a low dose of doxepin, especially if maintenance is the challenge. Non-benzodiazepine receptor agonist, a potentially benzodiazepine or melatonin, depending on which guidelines you look at. But really, the Z drugs are going to be your most appropriate thing to start out with, okay? In addition, always offer sleep hygiene. It's not going to be effective for chronic insomnia as a singular treatment, but certainly appropriate to offer for really anyone, even if they have occasional difficulty sleeping, so that they are aware of some of the habits that they can create to improve the likelihood that they'll have good, restful, consistent sleep.